After a lot of discussion with the fellow people in the dialysis units, we took up this topic of anemia in HD patients, clinical cases. So basically, to give an intro, we are all aware that chronic kidney disease and in dialysis patients, we have got anemia. Hemoglobin is on the lower side because of multifactorial reasons. But how to tackle this? We are all trained in the last 3 years. They're on anemia, erythropoietin, all other iron deficiency, and so on. So, but today we are not looking into theory. Here we are only looking into case-based discussion. We are going to discuss 4 cases today. We'll look into what is the lab reports, what are the things which has been done in these patients, and we'll assess each question regarding the case and then try to solve the problem so that when a patient comes like this to you again, you should be able to deal with it. So let's go to case one. A 68-year-old man on maintenance hemodialysis for 5 years and presents with progressive fatigue over the past month. So here the symptom is about progressive fatigue. So he's complaining of some weakness which is going on for over a month now. So in dialysis patient, you always encounter weakness, and there are many reasons for that. And the thing is that one of the common reasons which we look into is the blood levels. So in the lab reports which followed, it showed that hemoglobin is 10.8, and in last 6 weeks, it has fallen to 7.6. So definitely there is a drop in hemoglobin in this patient. The ferritin is around 210. The T-sat saturation is around 24%. What else followed was the reticulocyte count. The reticulocyte count was elevated in this patient. ESA dose unchanged. So monthly IV iron was continued, and neither the erythropoietin dose had any changes in this patient. So everything looks stable except but there was a sudden drop over 6 weeks. There's a drop in hemoglobin, and the iron as well as the ESA levels and treatment is going on stable. The blood pressure of this patient is stable, so there's no additional antihypertensives which is added. There was no obvious bleeding during dialysis. So definitely there is no additional blood loss during dialysis. So from the catheter or anything locally or from the insertion site or from the AV fistula, there was no obvious bleeding during dialysis. And dialysis adequacy was given as 1.2. So it seems that the patient is almost fairly dialyzed well. The blood flow also is very good, 350 ml per minute. So I don't see any problem there with the dialysis adequacy as well as the blood flow obtained from this patient. On further questioning, so when he was asked multiple questions relating to his weakness, he mentioned one very important point that he has recently noticed dark stools. So definitely he's mentioning about a presence of dark stools. So dark stools by definition is the color which is almost equivalent to your hair. So it's like a black hair or a black color stool or what we call as melena. So when you talk about take this patient into account, we understand that the hemoglobin of this patient is 7.6. And by definition, by KDIGO, we understand that hemoglobin less than 13 in male and hemoglobin less than 12 in female is definitely anemia. So we know that this patient has got anemia. And we also know that as the stages of CKD progresses, the patient's incidence of anemia also increases in these patients. And we are also aware in the previous lectures, we have heard that mainly in chronic kidney disease patient, there is definitely some blood loss or inflammation or reduced renal clearance, presence of uremic toxins, and decreased erythropoietin production, because of which there is a shortened RBC lifespan. Because of inflammation, there is increased hepcidin. And because of all these factors, in and additionally iron deficiency, these patients land up with anemia. And we try to solve this by adding our iron supplementation in cases with iron deficiency, erythropoietin administration in places with erythropoietin deficiencies, and also in patients where there is increased hepcidin and anemia, inflammation is more. In those patients, we finally resort to what we call as hypoxia inducible factor prolyl hydroxylase inhibitors. HIF PHI is what we normally known as Redustrostat, and the trade name which we are familiar with is Oxemia and Ristat. So these things are helping us in getting back the patient out of anemia. But with this, what are the questions related to our case? So what is the most likely cause of anemia in our case? We want to know which lab parameter is suggesting that there is an ongoing blood loss. We want to know what investigation we should order in this patient when we see such a hemoglobin of 7.4 suddenly over 6 weeks. Should we continue IV iron in these patients? whether blood transfusion will help and what level of hemoglobin should we consider blood transfusion, and what should be the dose modification you should do in erythropoietin stimulating agents. So when we look at this case again, reverse backwards, you will realize that these questions are the ones which we need to find solution. Now, when we look at the cause, because there is a rapid fall in hemoglobin despite adequate iron stores, adequate ESA therapy, together with history of melena, we definitely think that there is an ongoing GI bleeding. So here we are concentrating on a factor called as possible GI bleed in this patient, because of which this patient has got low hemoglobin. Now, when we look into dialysis patient, the causes which can bring GI bleed, one is peptic ulcer disease, that is some ulceration in the stomach. You've got some gastric erosions because of use of painkillers or aspirin, which is commonly a drug in these patients for cardiovascular diseases. Patient may have some vascular malformation like angiodysplasia, from where there can be bleeding in the GI tract. Patient can also by age have colonal malignancies or some polyps in the intestine which can bleed. Patient can have gastritis secondary to uremia, or maybe because of some medications, and because of which there can be a diffuse small oozing from the stomach which can cause this GI bleed. And lastly, very rarely but definitely in our population who have severe constipation, they may all have some history of piles or hemorrhoids in them, and that can also cause significant blood loss over a period of time and cause anemia. So definitely GI bleeding in our patient setup is very, very important, and all these causes has to be ruled out. So you must ask the patient about there is pain in the abdomen, location of the pain, whether it is above the umbilicus, that is in the epigastric region, whether they have any past history of such bleed in such patients, whether they have or on medications or somebody has prescribed them painkillers without giving antacids, whether they have got gastritis because of drugs, and also history of piles in the past or in the present, whether the stools are when they pass stools, and if they have fresh blood on that and the fresh blood is painless, then most likely it has to be secondary to hemorrhoids. And in this case, the history was very suggestive of a melena, that is a black color blood, the blood which is near the RBCs which are act upon the acids in the stomach, changing the color from red to brown to dark black. So that is why it is more of melena in our patients. So now what is a lab test which suggested to us that there is a possibility of a GI bleed? That was the elevated reticulocyte count. So you should understand that the bone marrow is responding by producing increased RBC. So the red blood cell production increases, definitely there will be increase in the reticulocyte count. And that is a response of the marrow to the blood loss. The other supportive findings which was there is the falling hemoglobin, the rising red density, the bit progressive fall in the ferritin and the TSAT. As the bleeding continues, sometimes there can be fall in ferritin because the iron deficiency comes from one of the most common causes, GI blood loss. So definitely over a period of time, you will see even iron going down. In the early phase, the iron may show normal report. And also, most importantly, in such patients, when you do a positive stool occult blood, so when a stool occult blood is positive, you know that it is probably secondary to a GI bleed. Always make sure that the patient is not on any oral iron medications for more than 1 week before the test. So you should never test a stool when the patient is on iron therapy, oral iron therapy. So you should ask them to stop the oral iron and then check for the positive occult blood, because it will give false positive reports. So definitely these things has to be kept in mind. Now you look at the investigations. So common investigations, when a patient you are suspecting GI bleed, the first thing to send is two local blood. Then common blood count, which is normally our CBC with the indices, because we need to know what is the MCH, MCV, MCHC in this patients. So when there is an iron deficiency, you will find that the MCV is low, MCHC is low. So you know there is iron deficiency happening in this patient. So complete blood count will definitely give us a fair idea, other than hemoglobin, the indicators whether there is associated deficiencies. Definitely, as we discussed earlier, reticulocyte count is most important, because the faster the response from the bone marrow, what we call as a baby RBCs, the reticulocytes will be more in the blood. So that indicates there is an ongoing loss and the bone marrow has been triggered, and the trigger is causing the release of reticulocytes formation, and that is what we are counting on the counter. Iron studies repeated, if there is a bleeding ongoing for some time, you can definitely see iron studies will be iron studies has to be checked to see for iron deficiency. Now, along with this, the blood loss can also be when the patient is on some anticoagulation. So definitely we need to know what is the coagulation profile of these patients. So sometimes what happens because of some diseases, like suppose some atrial fibrillation with thrombus, or because the patient has got a metallic valve, or because of some other reason, this patient may be on some anticoagulants. So we need to know whether the INR or PT-INR of this patient is correct or within the range of expected. Sometimes you have to keep, for example, between 1.5 to 2, and the patient is having a report of 4 or 5 or 6, that means the dose has to be readjusted. So coagulation profile is extremely important in such patients. Also, we need to review the medication. You have to go back and check whether the patient is on aspirin, clopidogrel, anticoagulants, and when there is an active bleed, then that definitely these drugs has to be put on hold and wait for the doctor's advice when to restart the particular medication. Now, when you talk about definitive evaluation, means these are the things are the indicators. Now we want to know what is the cause. Definitely, when you have got a stool occult blood positive report, we have to tell the patient that we need an endoscopy. So definitely an upper GI scopy. And if there is negative result in the upper GI scopy, then definitely we need a colonoscopy to go ahead and find out that whether this patient has got any bleeding point, polyp, any mass, or any other arterial malformation from where this bleeding or any ulceration. Because if we find a polyp, we can band it. If there is a particular ulceration, we can inject adrenaline into the ulcers and stop the bleeding. We can treat this thing and we can give a long-term antacid and antacid syrups, which can help us in preventing these ulcers to become bigger in size. If uremia is the cause of the gastritis, we can do good dialysis and try to reduce the urea so that uremic gastritis is taken care of. So many things can be looked into it. This, I just for the knowledge of everybody, I just put this up that in patients when you are not finding anything in the upper GI scopy, colonoscopy, but still the stool occult blood in many occasions is positive, then there is that 1 meter, 1.5 meter length where the ogidoscope as well as the colonoscope does not meet. So that length where which is not evaluated by the colonoscope and the ogidoscope is where we use what is called as capsule endoscopy. It is a capsule shaped camera which is swallowed in by the patient, and it travels through the whole GI tract, and the next day in motion it falls out, and then we take that camera and then we run the feed and then see where the bleeding is there, and if it is there then we look into how to go about it. And that is where also there's another easy method to find out is the CT angiography, where it will reveal the release of the contrast wherever there is an active bleed inside the intestine. And in rare cases, we use what we call as tagged red blood cell scans, where wherever the RBC is leaked, it will be highlighted in the scan. That is for those cases where we are not getting into any conclusive answer in spite of all the tests. So this is how we go about in this case where there is a occult blood positive, there is a drop in hemoglobin, and there is a high reticulocyte count. We do the following test and then give a definitive diagnosis by doing a endoscopy. Now, what are the thresholds for blood transfusion? That was one question we needed to answer. So in this patient, your hemoglobin is 7.6. There is a rapid decline. There's an ongoing bleeding. A transfusion would be reasonable in this patient. Because suppose a patient has got some cardiac illness or some other reason where hemoglobin has to be maintained because to decrease the workload on the heart, in such patients, definitely transfusion will help. If patient has got a lot of symptoms, he's not eating any food, he's feeling persistently weak, lethargic, cannot do anything, he's not able to sleep well. All these anemia, the symptomatology is at the rise. In those patients also, transfusion will be reasonable. Patient's symptoms should be the one which should guide us for the transfusion after the definitive treatment or during the definitive treatment. For patients for blood transfusion, whenever you give, we have a simple dictum that we should be very careful and we should plan for the kidney transplant patients. We should never use blood transfusion unless it is an emergency like a surgery where we need to transfuse blood or patient's cardiac status is at toll because of the low hemoglobin. Only those cases we use leukocyte depleted blood transfusion for those cases because blood transfusion can have some interference with the cross match of the patient later on during the transplant workup. So on those patients, you should be very careful with the blood transfusion. Now, when coming about ESA dose, so here the patient's hemoglobin is 7. So should I go and change the ESA dose directly? So when I know there is a possible GI bleed, I know that there is a possible associated iron deficiency. There is a possibility that patients cause can be corrected. As soon as the cause is corrected, automatically with transfusion, the blood will come up. We should continue the same dose of ESA which is going on, because this is not secondary to ESA dose deficiency. It is because of a blood loss there. So we can continue this for a couple of weeks and see how's the hemoglobin behaving. If the hemoglobin does not rise and we need to hike, then only you should consider. So adjust the ESA only if the hemoglobin remains below target after the bleeding has resolved and the iron status is adequate. So in this condition where there is a GI blood loss, you should be very careful on about the hiking of ESA. You can erythropoietin doses can be adjusted as and when needed, depending on the reports what we get and the symptomatology of the patient. So what did we learn from this case? So that is very important. The learning points from case number one is a rapid fall in hemoglobin in a stable dialysis patient should always prompt evaluation for blood loss, especially in these patients who are having most likely chance of GI bleeding. An elevated reticulocyte count indicates an appropriate bone marrow response and points towards blood loss or hemolysis rather than reduced red cell production. So, whenever there is a rapid blood fall and there is a requirement for RBCs, the bone marrow is stimulated, the reticulocyte count will definitely go up. It is an indicator that there has been a blood loss, and the bone marrow is just responding to that, which is a normal response of the body, and that can be picked up by elevated reticulocyte, an indirect marker for us to understand there is a drop in hemoglobin. Melena is gastrointestinal bleeding until proven otherwise. So whenever you see a black color stool, first thing in your mind should be there is a possible bleeding. Secondary causes can be many. You have eaten something which is having the color like that, or you can say many other reasons. But most importantly, whenever you see melena in a patient, we should first think about to rule out GI bleeding. Reflexly increasing the ESA, always avoid. So you should not directly increase the dose of ESA. Hemoglobin is 7, okay, now increase to another 4,000 units of subacute erythropoietin. No. We will take, when we know that there is an acute blood loss, we should focus on continuing with the same ESA dose and continuing with the measures required to stop the bleeding, and then see whether the hemoglobin responds to that, and then not, then only consider to rise the ESA levels. Reassess iron indices, because in most cases of prolonged small bleeds, the iron will be depleted, and in those cases, just by giving the corrective measures, it will not respond. The hemoglobin would require to respond only when even the iron is completely depleted. So iron studies or indices are also important to be observed in such patients. So this is what brings us to the end of case one, where we learned so many different aspects about this particular GI bleed as a cause of anemia, and how to assess the lab parameters, and how to not increase the ESA dose, correct when to give blood transfusion, and also the importance of iron therapy in such patients. So now let's go to case number two. A 54-year-old woman on hemodialysis, now for 18 months, complains of worsening exercise tolerance and decreased appetite. So again, here there is a patient who is saying that whenever she climbs stairs, she's feeling little tired, breathless. She's not able to do the same set of activities as she was doing before. She's feeling there is a drop in her appetite. Definitely, she's not eating well as before. And the current treatment is patient is on darbepoetin 40 mcg every 2 weeks as expected. The dose is correct. There is no IV iron given for the last 3 months. So because the patient was having good hemoglobin, probably they were not giving any iron therapy for these patients, or maybe that at the time when they checked last 3 months before, the ferritin, the iron stores would be replete or even more. So they decided to stop iron then. And so the patient was not receiving any iron for the last 3 months. Now we look at the lab values. The patient's hemoglobin is 8.4. So by definition, definitely the patient is anemic, is below 12. Ferritin, 48 nanogram per ml. So ferritin is extremely low. So ferritin indicates the store of iron. So storage is less. T-sat is 11%. So transferrin saturation is also extremely low. We expect around 30%. CRP is normal. So why CRP? CRP indicates inflammation. So inflammation, there is no infection or inflammation in this patient. So CRP is fairly okay. MCV is 72 FL and reticulocyte hemoglobin is low. So here, to the contrary, your reticulocyte is not high. Here the reticulocyte is low. So definitely it is not indicating any blood loss over here. There is no infection in this patient. That's what I understand from this. I also understand that the iron stores are extremely low, and there is an history that no iron was given for 3 months. and I see that the patient has got all symptoms of anemia like worsening exercise tolerance and decreased appetite. So what are the questions we have to ask ourselves? What is the diagnosis in this case? What we know about absolute versus functional iron deficiency? Is oral iron useful in dialysis patient, or is it IV is preferred? What is the target ferritin? What is the target TSAT values to be achieved in such patients? And should ESA be increased immediately in these patients as well? So types of iron deficiency, we are very aware that absolute iron deficiency, that is iron stores are depleted, the ferritin is low, the TSAT is low. In our patient also, the ferritin is low, TSAT is low. Typical values of ferritin less than 100, our patient is only 40, and TSAT is less than 20%, so definitely here that is also low. So our patient fits somewhere in an absolute iron deficiency state. That is what I understand from this definition. Functional iron deficiency. What do you mean by functional iron deficiency? That iron stores are adequate. That means your ferritin is correct, your TSAT is correct, but iron is not available for erythropoiesis because of inflammation and elevated hepcidin. So in chronic kidney disease, in inflammatory is a high inflammatory state, the hepcidin levels are more in the blood. They block the usage of iron for erythropoiesis. So in spite of having iron adequately present, it is not reaching the factory. So there are iron loaded in the truck. The truck is outside the factory. But there are some people like Hepcidin watchmen and anti-socialist people who are not allowing the truck to enter the factory to form hemoglobin. That is, the production is not happening because the ingredients are not available. That is your functional iron deficiency. So what happens with the lab values? How will I identify whether it is functional iron deficiency or absolute iron deficiency? So in functional iron deficiency, the typical values, ferritin is normal or high. So the store is full. Here in our patient, the ferritin is low. TSAT is less than 20%. CRP is elevated. Obviously, when there is inflammation and infection, the CRP will be elevated. The patient has normal CRP in our case, making functional iron deficiency unlikely. So in our patient, what we understand is this anemia is secondary to iron deficiency, and that too absolute iron deficiency. Now the question is about oral iron. Whether oral iron is our first line of therapy in hemodialysis patients. So your answer is, you all are aware of it. The answer is no, not as the first line therapy in hemodialysis patient. Why no oral iron? Why we don't use oral iron in our patients and only use IV iron? Because the most important point here is that in CKD patients stage 4, 5D and patients on dialysis, poor gastrointestinal absorption of iron. That is almost less than 30%. Elevated hepcidin in CKD also reduces the absorption of oral iron. The slow correction of deficiency, it takes a lot of time for that iron to correct the iron deficiency because of its presence and availability from the drug is less. So bioavailability is low. There are frequent GI side effects. So what are the problems with oral iron? We get gastritis, we can get constipation. So that part has to be also looked into. And inferior efficacy compared to IV iron. So we are all aware that IV iron availability as well as efficacy is much better than oral iron in patients who are on hemodialysis. So that is another reason why we are looking into this, as oral iron is not an adequate first line therapy for patients on requiring iron therapy on dialysis. Now, what about IV iron? How will we treat this patient of ours? So we definitely have to give him IV iron to replace the iron deficiency which the patient has. So iron sucrose, if you're using iron sucrose, it will be 100 milligrams IV after each dialysis session. So total cumulative dose first 10 dialysis sessions, you will complete the overall quota of 1000 milligrams, and then probably continue the maintenance as required after again reviewing what are the blood levels of iron, TSAT, and ferritin. So we need to reevaluate that thing after 8 weeks to see what is the correct current iron values to again decide on the maintenance dose. Ferric carboxy maltose 500 to 1000 milligrams you can give safely at one shot. We are always saying that the dose has to be finished within 15 minutes. So we can, one more thing which we all need to understand is iron is not dialysable. So hardly 3% of the iron is dialysable. So we generally give iron during dialysis, and you can finish that in that last hour of the dialysis session. In case of iron sucrose, we can start early. the point is that we do need not, like initially we used to write prescriptions, we used to write iron, so 100 milligrams to be given post HD. But basically, this to save the time in dialysis for the next patient, you can definitely give iron during dialysis. It is completely safe. And another thing is with ferric carboxy maltose, when we give, the reaction is less, side effects are less, easy to administer larger doses. So we just need 2 doses of ferric carboxy maltose, and that will be good enough. We can give it to back dialysis sessions, or weekly one dialysis session we can give to make the complete replete, and then we can monthly give 1 dose. That will be good enough to maintain the iron ferritin level in this patient. The difference is in the cost. So where affordability is the criteria, we definitely, in patients who are difficult to buy iron carboxy maltose, we give iron sucrose as per the availability and the local support which you have for the same drug. There are also iron isomaltidose, and that is also a very safe drug. It can be given at a single infusion, but much costlier than the above two. So it depends on the this individual, and the maintenance dose is also planned as per the reports. And we know that the newer KDGO 26 iron targets TSAT to be maintained about 30%, up to 30%, and ferritin initially was up to 500. Now they are mentioning that it can go up to 700. So that two values which we need to remember as far as KDGO targets for iron is concerned. So what was the learning points from this case? So we understood that low ferritin and low TSAT is an absolute iron deficiency until proven otherwise. And in hemodialysis patients, IV iron is preferred over oral iron because of the better efficacy. There is a situation, a clinical situation, where some patients, in spite of the safest iron like iron carboxy maltose or iron sucrose, they get reactions. These are the few set of patients in which we use oral iron. Otherwise, we generally avoid oral iron in such patients. Iron should be corrected before escalating ESA therapy. So the question there was, when can we escalate ESA therapy? So obviously we understand that when there is a definitive iron deficiency, we know that first initial pro-erythroblast to the normoblast, the initial phase of erythrocyte formation requires the help of EPO, and the final maturation requires the presence of iron as a cofactor. So with both together in equal amounts, only the hemoglobin can be completed, the process can be completed. So iron should be corrected first before escalating the ESA therapy, because sometimes it may not be required to escalate ESA. With iron correction, automatically the hemoglobin will be settled. Now, when we look at the other marker, which is the early marker, we are not using it commonly, but in studies, definitely we use it, low reticulocyte hemoglobin, which gives us a fair idea, and pick up the earliest when the hemoglobin falls. Always investigate why the patient became iron deficient. So is it that there's a nutritional problem where patient is not having iron properly? Is that the patient is having any GI loss because of which there is iron deficiency? Anything related to the worms and parasites, where the patient is not dewormed regularly? Then deworming is an important element to be done in dialysis patient once in 3 months. So deworming should be concentrated at. So once the first time when you come across a anemic patient, always remember to give prescribe albendazole 400 milligrams, one tablet at night, only one tablet on that particular night, so that they are dewormed. So that first process is through. The one of the factors which are commonly present in these patients is worm manifestations. And so we learned from this case that you have to look into ferritin and TSAT and decide whether there is a true iron deficiency or a functional iron deficiency. And then we also learned that these iron can be corrected IV, which is more better and superior over oral therapy, only given in patients who have got IV iron reactions, and always try to investigate why there was iron deficiency in that patient. So that brings us to case number 3. A 62-year-old diabetic on hemodialysis receives epoetin alpha 10,000 international units per week. Hemoglobin still remains at 8.1 grams per dl. So patient is getting adequate EPO for sure, but hemoglobin is at 8.1. Let's see the lab values to understand further. You are looking at the ferritin, it is 620, very adequate. TSAT 28%, almost adequate. CRP, the inflammation, CRP is 54. So patient has got some inflammatory state. Albumin is 2.9. So this patient is somewhere, maybe a case of chronic liver disease, or patient's nutritional status is not good. Something is missing in this patient. about the nutrition, or a patient has got some liver disease. PTH 980 picogram per ml. So definitely the patient has got hyperparathyroidism. So normal PTH is 15 to 65. And we know that in CKD population, we keep the PTH levels 5 times the normal. So it will be around 3 till 300. We can accept if there is no symptomatology in place when the patient is normal calcium, no bone pains. We generally treat beyond 300. So this patient definitely we have to look for ultrasound neck to look for any parathyroid adenoma, or is it this as part of the secondary hyperparathyroidism which needs the tablet named cinacalcet for the treatment for the same. So definitely this patient has got hyperparathyroidism. And also the patient history mentions that the patient has got a dialysis catheter in situ. If I have to connect between the 2 points, that there is a dialysis catheter in situ and there is a CRP of 54, so there is some infection in the body. It may not be that catheter related infection, but can be also catheter related infection. So I need more history on the patient, whether the patient has got any fever during dialysis or just about terminating dialysis or start of dialysis or at home. That history is very important in this patient to understand whether it is the catheter related bloodstream infection causing this problem. So that part has to be definitely looked into. So in this case, till now, I understood that there is a 62-year-old diabetic who has got 10,000 units of regular erythropoietin ongoing with a hemoglobin which is on the lower side, with normal iron studies, with inflammatory markers CRP high, with low albumin marking probable CLD or malnutrition, with hyperparathyroidism 980 picogram per ml, and also patient is a case of dialysis is doing through a dialysis catheter in C2, probably may have a catheter related bloodstream infection. So what are the questions I should ask this patient? That is there any iron deficiency in this patient? No, I don't think there is any iron deficiency because we saw that the parameters of iron, both TSAT and ferritin, completely fulfills the criteria. Whether this patient has got erythropoietin stimulating agent hyporesponsiveness. So whether the patient has got any hyporesponsiveness to it, because erythropoietin is being given, but there is no response. Hemoglobin is 8.1. Whether why there was a high ferritin in this case, whether ferritin is misleading in this case, what should be the correct action before increasing the ESA therapy? What should be correct first? And should we consider to add, because erythropoietin has failed and iron studies are fine, but still the hemoglobin is not up, which in most of the cases, then we look upon this particular drug, the HIF PHI inhibitors, that is your hypoxia inducible factor, prolyl hydroxylase inhibitor, which is our oxemia or tristat, whichever the molecule we are using in your personal dialysis units, the reducostat. So whether we should use desidostat, that is the next question. So let's see what are the answers. So before that, we should understand that the dose of 10,000 units of erythropoietin there the patient received. So we know that we have got erythropoietin alpha, beta, darbepoetin, and also continuous erythropoietin receptor activator, SERA, set of drugs. Nowadays, for a quite long time, many of the units or many of the people who are just joined the dialysis units so in practice will not be aware of the word SERA, continuous erythropoietin receptor activators. But before, another 5 7 years before, this was the drug of choice in most of the patients of anemia and dialysis, that was traded by the name Mircera. So what we are looking at EPO, we know that there is sites of route of administration remains same for all the four parameters, that is subcute. The dosing was 50 to 150 units per kg depending on the dose. We used to divide it into 3 times a week or 2 times a week for erythropoietin. Darbepoetin, because of the longer half-life, we could give it once in 2 weeks. And SERA, that is your continuous erythropoietin receptor activator, in that case, you could have given it once in a month. In most of the patients, only one shot in a month was sufficient to maintain the levels of erythropoietin stimulation, and that continued. For people who are not aware of SERA, I just try to give you a few more idea about it. It's a continuous erythropoietin receptor activator, a third generation ESA. It is a pegylated form of erythropoietin beta. So you're just pegylating. Pegylation means what? You're just adding a large flexible polymer. As you see in the diagram, this dark blue color with is your primary epitopoietin, and you see a very large light blue color molecule, a glycopolymer is attached to this particular erythropoietin beta. Then it is this whole structure, the huge large structure is called pegylated molecule, And the pegylated molecule, the advantage is that it helps the drug to remain in the body longer and provide continuous activation of the receptor. So prolonged duration of action. That's what happens with sera. So it is basically a recombinant technology, and what we generally do is mechanism of action is by continuous activity. It is not the amount of stimulation of the receptor. It is about the faster dissociation from the receptor to get inside and stimulate. Then, because of its long presence in the blood, it keeps on continuously and endogenous erythropoietin production is increased, and that is how it is able to maintain a single monthly dose for this particular molecule. It is a safe drug. Its extended half-life is 134 hours. So definitely today I'm feeling very happy to introduce you to this particular set of erythropoietin, which is your SERA, which is continuous erythropoietin receptor activators. So coming back to our question, whether in spite of giving erythropoietin, we didn't see any response, and that what we term it as ESA hyporesponsiveness. So when we talk about ESA hyporesponsiveness or ESA resistance, it is a failure to achieve or maintain the target hemoglobin despite appropriate or escalating dose of erythropoietin stimulating agent after correcting the reversible causes. So in spite of correcting all the reversible causes and regularly increasing the levels of ESA, if you are not able to get the hemoglobin level up, when you are definitely dealing with ESA hyporesponsiveness. There are multiple definitions of ESA hyporesponsiveness which you can get from your textbooks. But clinically, when I look at a patient, I understand that if the hemoglobin is persistently low despite very high ESA doses, when I am needing to progressively increase the dose of ESA. So patient was taking 4,000 BD, then I made it 10,000 a week. Then I'm using more than 14, 16, 20,000 per week. So I'm increasing the dose of ESA more than 50% each time with no rise in hemoglobin at two occasions. Then I know that I'm dealing with something called as ESA hyporesponsiveness. And there is a little or no rise of hemoglobin in spite of 4 to 8 weeks. So clinically, all these three parameters give me an idea that I'm dealing with a patient of ESA hyporesponsiveness. And what are the causes of ESA hyporesponsiveness? 70% of the time we get to know that either we are dealing with iron deficiency or there is an inflammation due to infection, dialysis catheter use, or autoimmune disease in these patients. Maybe patient will be having hyperparathyroidism, which deflects the total output of erythropoietin therapy, blood loss because the patient is losing from GI procedure menses, inadequate dialysis, patient is not adequately dialyzed, so uremic toxins present, not allowing the hemoglobin to rush through, malignancy in the patient, hematological disorders, nutritional deficiencies, and medications like our RAS inhibitors, losartan, telmisartan, and lisinopril, captopril like drugs. But still, 30% of the cases remain unexplained. We have to know that ESA hyperresponsiveness can be because of anything of the following. So that is where the role of HIF-PH inhibitors, when HIF-PH inhibitors, basically what it means is just think that there is a stimulation required for production of EPO, and the stimulation in the body is when the oxygen level in the blood is less. Oxygen level is carried by hemoglobin. So if there is a hypoxia in a intracellular level, it gives a signal to a particular molecule to go and produce erythropoietin. When erythropoietin is produced adequately and hypoxia is completely cured with O2 presence of oxygen back to the tissues, this molecule is degraded by hydroxylase, prolyl hydroxylase. What here the HIF-PH inhibitors does is the messenger which goes and stimulates the erythropoietin, it goes and blocks that enzyme which breaks this messenger. So the messenger is always present and it keeps on activating the production of erythropoietin. This is exactly what your desidostat or roxadustat does for you. So it increases the endogenous erythropoietin, it reduces the hepcidin. So when you reduce the hepcidin, it will reduce the blocking of iron usage. So iron will be freely available for erythropoiesis. It will improve the erythropoietin level. So you have EPO, iron coming up together in a bigger way and the hemoglobin improves. So and that is why the patients who are hemoglobin you will see as 8, 7, 6, 5 or that low hemoglobin within a month or two going up to 8, 9, 10 respectively. and it is basically placed as a dose of 100 milligrams tablet, which can be given post dialysis. If a patient is on 3 per week dialysis, you can give post dialysis to the patient. So that continues over a month, and then you again recheck your hemoglobin parameters, and you will find that you need to titrate the dose once you reach the ceiling effect of 12, 13 hemoglobin. You can reduce the dose from 100 to 50 and then titrate the dose accordingly to patient's needs. So advantages which it has over erythropoietin is that it is basically oral tablet. It is not an injectable thing. So many patients like to take this drug. It is relatively small, but physiologically it increases the erythropoietin levels. It lowers hepcidin, we discussed. It is beneficial in patients who have got hyperresponsiveness. When it can be reduced when the hemoglobin is target. There is no adverse effects like hypertension. So blood pressure variation which we see with ESAs are not there with this drug. Adverse effect is that because it's an angiogenic drug, it definitely may have tumor potential proliferation. If patient has got a proliferative diabetic retinopathy, we have to be careful, and regular eye checkups are important. Patients who have got pulmonary artery hypertension, in those patients also we need to adjust the dose of sildenafil to make sure that the pH is controlled. And patients who have got changes in glucose, fats, and cholesterol metabolism can be titrated accordingly. So in this patient, where we saw that the hemoglobin was low, we could understand that the reason is probably because of the ESA hyporesponsiveness, and the main contributor, multifactorial in this case, because we saw that the patient had inflammation. So there was some chronic inflammation going on. Patient had functional iron deficiency because stores were full, but patient did not have the hemoglobin was lower. Patient had a severe secondary hyperparathyroidism because PTH was approximately 980. And patient definitely had low albumin, can be because of CLD, but not in this case mentioned. So most likely because of protein energy malnutrition. And also patient had catheter related inflammation or infection, because of which the catheter was in place. So probably from there was this one element of inflammation, or probably he had infection. So in this case, we learned that the response to erythropoietin was less because of all these multiple factors in this patient. So what are the learning points here? A practical approach to remember the reversible causes is a mnemonic. Iron pin. We know that our pin is made up of iron, just think like that. So I is for iron deficiency, R is for reduced dialysis adequacy, O is for ongoing inflammation or infection, N is for nutritional deficiency, P is for parathyroid disease, that is hyperparathyroidism, I is for inhibitory medications or marrow disease, and N is for new blood loss or hemolysis. So you are looking at iron pin as the causes of most common causes, which cause the reversible causes, which can be helpful in reverting this, and we can correct the anemia without much erythropoietin activation. So now going to the next and the last case of the day, a short case of case 4 of a 71-year-old man on dialysis, and he has got persistent anemia. Now what happens here is the patient is treated with high dose ESA, he has got adequate IV iron, everything is going on, but patient is having still persistent anemia. And if you look at the levels, there is something very catchy in this. The hemoglobin is 6.8, the WBC is only 2,800, and the platelet is only 88,000. The patient never had any fever or anything to suggest that there is a viral illness causing such low values. So there looks something wrong with the bone marrow when we look at these reports, that there is some low activity from the bone marrow. The ferritin is good, 580. PSAT is 32. Reticulocyte count is very low. So again, something indicating that the bone marrow production of the RBCs. Get the most important test. So the most important test in the patients here is a peripheral smear. So we do stool occult blood. We learned in the first. Iron and iron studies we learned in the second. Third, we learned about the other parameters which can decrease the response of ESA, where we mentioned about tests like PTH, CRP, our blood indices. And now, most importantly, one of the another most important test in the what do you say investigation profile of anemia is peripheral smear. So in this peripheral smear, you can see there are large cells, macrocytosis, and dysplastic neutrophils. So the neutrophils are not looking normal. It's some dysplasia is there in the neutrophil cells. Now the questions asked is why, in spite of giving so much of erythropoietin, it is failing. What is the most likely diagnosis in this case? What investigation confirms the diagnosis? And should iron continue in this patient? And how should anemia be managed in this patient? So why is ESA failing? The evidence says that patient is already on very high ESA, adequate iron stores, very low reticulocyte, pancytopenia. That is the word used for low HB, low WBC, and low platelets. So all three lines are low means it is pancytopenia. All the cell lines are down. Macrocytosis. This strongly suggests that the bone marrow failure is there rather than iron deficiency or inadequate ESA dosing. So what we are looking at is a myelodysplastic syndrome. Bone marrow studies is the investigation of choice. So here there is a bone marrow failure, and in spite of giving everything, the hemoglobin is not coming up. In our dialysis patients, some patients agree for going ahead with bone marrow studies. It is very, very important. If you are not getting an answer to your anemia because of all the possible things which we discussed in the above four cases, then there has to be something related. And with this cell line, we must think about bone marrow disease, and that is where we must do bone marrow studies. So, what are the learning points from this case? Pancytopenia plus macrocytosis plus low reticulocyte count. You must think about bone marrow disease. Iron deficiency always causes microcytosis. You have already seen peripheral sphere of so many patients. Whenever you see iron deficiency, it is micro. So I always say the students should remember it is I for iron and micro is MIC. Macro is always A. I is only micro is I. So iron deficiency is micro and MDS is macro. A very low reticulocyte count indicates impaired marrow production. Escalating ESA indefinitely is not appropriate. So not there's no point in increasing your ESA in these patients. And always in unexplained refractory anemia where you're not getting the answer for it, please go ahead and do a bone marrow biopsy. Very, very important. Bone marrow biopsy has to be considered in patients who are having unexplained refractory anemia and when all the cell lines are down. So, if I had to summarize today's five clinical cases and what we studied from them, we always should think whenever you're talking about blood loss, you should talk about falling hemoglobin, high reticulocyte count, iron deficiency, you should look for low ferritin, low TSAT. Whenever you're talking about ESA hyporesponsiveness, you're thinking about inflammation, infection, hyperparathyroidism, malnutrition, and inadequate dialysis. You should remember the iron pin. When you're talking about bone marrow disease, you're looking at pancytopenia, macrocytosis. You're not looking at microcytosis. Micro, I means iron deficiency. So iron deficiency as microcytosis. This is macrocytosis, low reticulocyte count. And when you're looking at metabolic toxic causes, which are not common now, earlier it was there, aluminum toxicity and other things, which are not relevant to today's time. So please consider these basic steps that is about our three most important tests, two local blood, never forget, iron studies, never forget, peripheral smear, never forget. In a case of anemia, where it is other than ESA hyporesponsiveness or iron is complete, and then you're evaluating for the causes of anemia, think about all these basic steps to be sent and find out the cause and treat so that we are not unnecessarily making the patient spend money and time on getting higher doses of erythropoietin and unwanted doses of iron therapy. Thank you.